Hello, I'm Mark Gurnell from the University of Cambridge in the UK, and the topic of this lecture is the management of non-secretory pituitary tumours when surgery fails. I'll begin just by confirming that I've got no relevant disclosures. So I think it's important to clarify a couple of points before we consider the specific question. In particular, what do we mean by fail? The dictionary definition of fail is a verb, meaning to be unsuccessful in achieving one's goal, which begs the next question as to what are the goals of surgery in non-secretory pituitary tumours, sometimes referred to as non-functioning pituitary adenomas. And I would contend that they are threefold, really. The first is to protect, stabilise, or if we need to, rescue vision. Second, to preserve and, wherever possible, recover any lost pituitary function. And thirdly, to limit the need for adjunctive therapies so that the patient doesn't have to go around repeated cycles of treatment. So here are some of the key factors that I always think about when considering recurrent or indeed residual non-secretory tumours. First off, do we have good enough imaging, ideally pre- and post-treatment imaging available, standard T1, T2 sequences, but there may be additional sequences available? Do we have the information relating to the first operation? What was the ease of the surgical access, the extent of the resection? Was the normal gland visualized or not? Any issues around CSF leakage, either intraoperatively or postoperatively, or indeed any other complications? Do we have all the requisite information related to the pathology of the tumour, in particular the standard H&E, immunohistochemistry, cell lineage markers, proliferation markers, etc.? Do we have the endocrine and non-endocrine status of the patient assessed? Do we know the pituitary function, visual function, presence of comorbidities and other relevant factors, such as, for example, future plans for pregnancy and whether there's any relevant family history? Is our centre a centre of excellence or pituitary tumour centre of excellence? And therefore, do we have the requisite skill set when it comes to not just endocrinology, but neurosurgery, if necessary, with otolaryngology, oncology, radiology, pathology, etc.? And then perhaps the most important decision of all, what is the patient's perspective on things? Whatever we recommend treatment-wise, if it isn't acceptable to the patient, then it isn't likely to work. So what I propose to do is to use a series of short cases just to illustrate some key aspects of how we can manage such patients. This first case is a 44-year-old woman who presented with progressively deteriorating vision. Her past medical history was notable for congenital cataracts, and unfortunately she had no useful vision in her right eye, long-standing. Left cataract surgery 6 months earlier had not produced an improvement in her vision. Her only relevant past medical history was hypertension treated with amlodipine 5 milligrams a day. And her blood pressure was a little above target, but there were no stigmata of other features of endocrine dysfunction. And you can see that whilst she only had hand movements in the right eye, it's not possible to do a visual field. In the left eye, the visual acuity was slightly reduced to 6/12, and just a suggestion that there might be an upper quadrantic early defect on that left side. And of course, we can see the normal blind spot below. Now, this is the initial scan. You can see T1 sequences in coronal and sagittal plane with and without gadolinium. And we've also got a T2 fast spin echo sequence in the coronal plane. So there's clearly a large macroadenoma extending to a butt and indeed compress the optic chiasm, and a suggestion that there's also some potential lateral extension. The baseline biochemistry is as shown. All results throughout this talk will be presented in a similar way. Anything which is in grey is within the reference range, and that reference range is shown under the particular parameter that's being measured. Anything in blue is a low value. If you see anything that's in red, that signifies an elevated value. And here we can see there's a picture suggestive of possible borderline mild central hypothyroidism, well-preserved serum cortisol level, normal prolactin, but evidence of hypergonadism, and an IGF-1, which is difficult to determine whether that is normal or indeed could suggest a degree of GH deficiency. So we're not going to actually be able to straw poll the audience here, but just to get you to think for a minute about if you met this patient in the clinic and the patient asked you, how confident are you that this operation is the only treatment that they're going to need for this? It's interesting to think about whether we would suggest that we have no confidence at all, or at the other end of the spectrum, very confident, or somewhere in between, i.e. slightly confident, somewhat confident, or fairly confident. And of course, there's no absolute right answer here, but it might be something you just want to think about for a moment. Now, I'd argue in this patient that there are some key considerations that need to be taken into account before you can really start to answer that question. One is the NOSP grade of the tumour, i.e. the extent to which there is cavernous sinus extension or invasion. You may have also noticed some interesting appearances on the T2 weighted MRI, in particular the suggestion of cysts, both micro and macro cysts. Perhaps you noticed that the pituitary function tests show a surprisingly well-preserved 9 AM cortisol, despite the apparent presence of mild central hypothyroidism. And here there's some important specific patient factors. This is a woman who may still desire fertility, but also she has this particular individual context of monocular vision. So some important things to remember when we're looking at the imaging preoperatively: can we see the chiasm? Do we know where the normal gland is? And what is the extent of the paracellular invasion as graded by the NOS classification? This is the updated modified NOS classification published in 2015. And just to remind you, there's a series of tangents going through the medial, the mid, and the lateral segments of the intracavernous and supracavernous carotid artery. And this tumor has actually got as far as to extend beyond the lateral tangent, which in essence makes this a NOS 3A tumor. Now, it might still be surgically resectable, but is slightly more of a challenge. Also, I just alluded to the fact that on the T2 imaging, there were cysts, small cysts, but also potentially some slightly larger cysts. And this is a very elegant paper, which is now a decade old, which just correlates the presence of microcystic changes on T2 weighted MRI with the presence of a corticotroph lineage. Either a silent corticotroph tumor, where these are much more prominent than they are within non-secretory, non-functioning tumors, or even in some actual secretory corticotroph tumors. So what actually happened in this patient? Well, in the theatre, a large tumor underwent a gross total resection. There was no specific comments or concerns. This was focally positive pituitary adenoma, classic appearance, SF1 lineage positive, with no excess of proliferation markers. And post-operatively, we achieved a good result. You can see from this scan that the chiasm is nicely decompressed, and now we're left with some residual tissue within the floor of the cellar. The vision is stable, and in fact, we have a normal visual field in the left eye now with a slight improvement in acuity. We still have evidence of central hypergonadism, but we've now resolution of the apparent central hypothyroidism, and we still have good preservation of 9 AM cortisol, perhaps a slightly low IGF-1. So we're comparing on the top row here the preoperative images and the 6-month post-surgery images on that bottom row. So now you hold those in mind. If that patient now comes back to your clinic and asks, how confident are you that this tumor has been removed and I won't need any more treatment? I wonder what your answer would be now. Would you be feeling more confident about things or less confident about things? So in actual fact, at this point in time, the patient was quite keen to elect for a conservative approach. And 6 months after that initial post-operative scan, you can see that there was very little change in the MRI. And it's interesting to, again, think about whether you would answer that question slightly differently at this stage, or whether you would still be sticking to your original thoughts. However, by 24 months, I think most people here would now agree that there looks to be an increase in the amount of tissue now on the left-hand side of the cellar and the left cavernous sinus region, suggesting that actually, even though it wasn't possible to be certain on the post-operative imaging, probably this area on the left side of the cellar was indeed residual tumor, unlike this area, which is slightly less enhancing towards the middle of the gland, which is probably more scar tissue. So probably at this stage, your confidence about this not needing any more treatment is diminishing. And the patient eventually felt that actually by this stage at 36 months, when there was clearly a further increase in the size, that actually now was the time to do something again, especially in view of her monocular vision. And she went on to repeat transsphenoidal surgery and radiotherapy, and I'm pleased to say is now in remission. I think what this case illustrates is you need to assemble all the information together in order to be able to make a balanced decision as to whether to recommend treatment, adjunctive treatment, when you think there might be incomplete surgical resection. Either is it going to be at an earlier stage or is it going to be at a slightly later stage? With close surveillance, there's often an opportunity to wait and see. So I'm going to move on to case number 2. Case number 2 is a 75-year-old gentleman who collapsed while he was on holiday and was discovered to have hyponatremia. That triggered imaging, which actually initially on CT and then subsequently on MRI revealed a pituitary mass. He had a history of ischemic heart disease. When he came in, there was no stigmata of endocrine dysfunction. He was not hyper or indeed hypotensive, and he had the suggestion of an early bitemporal cut on his visual fields with a slight reduction in the vision of 6/12 in acuity in the right eye. Here is a lesion which is cellular and supracellular based, up to and extending towards, and indeed probably compressing the optic chiasm. And again, this is a man with not too dissimilar a picture of biochemistry to our first patient, with a pattern of central hypothyroidism, reasonably well preserved 9 AM cortisol, but a clear pattern of central hypogonadism. Now, this patient was operated elsewhere, so we don't have the details of the operative note. All we know from the routine reporting of the pathology was that there were no positive immunohistochemical stains for hormones. There was no lineage markers done at that stage, but nothing untoward in the proliferation markers. So this was felt to be a typical non-secretory or a null cell pituitary adenoma as described at that stage. And here is the post-operative imaging suggesting that there has indeed been a debulking, and indeed vision in terms of both acuity and fields is fine, but we've still got a similar pattern of hypogonadism. And although the thyroid axis has improved, we now appear to have a degree of central hyperadrenalism. So here again, we can see the pre-surgery results and the post-surgery results. There's certainly a debulking, but I think most people would agree that there looks to be a significant remnant. So this patient was referred to our service at this stage asking, do I need to have more treatment now? And it'd be interesting again to hear what people would think. So again, you can consider yourself, what more would you recommend at this stage? Would you argue for commencing dopamine agonist? Would you refer this patient for radiotherapy? Would you offer repeat transsphenoidal surgery? Would you think about stereotactic radiosurgery? Or do you think that surveillance, combining clinical, ophthalmic and radiological, would be reasonable? Well, here he is pre-surgery. Here is that post-surgery imaging showing a reduction and stable fields. Here we are 18 months out post-surgery. So suggestion that the lesion might be increasing a little bit, but no change to the vision clinically. 3 years out, still no change to the vision. And in fact, by 11 years out, probably a tumor that is bigger and now possibly starting to affect the vision. But actually here, more than a decade without further intervention. And the important thing is that at this stage, the patient was 86 years of age, no longer driving for other reasons, actually was no longer interested in any further intervention, and actually had unfortunately developed a comorbidity with quite significantly elevated PSA and a diagnosis of prostate carcinoma. And actually, you could argue in this situation that perhaps earlier intervention might have prevented this from growing, but actually this patient was very happy with a decision to pursue surveillance here. And in actual fact, at the end of the day, still has no change to quality of life, still has good enough vision to do everything that he needs to do normally. And this would be an argument for saying that surveillance can be the right treatment for some patients. There has been debate as to whether actually dopamine agonists for some patients with non-secretory adenomas may present an alternative, if you like, more conservative approach to management. Here's a nice study comparing some non-functioning secretory tumors, which were more staining for dopamine 2 receptor on immunohistochemistry than others, showing that actually the tumors which were most likely to stain for dopamine receptor subtype 2 were most likely to be those, those that stain for dopamine receptor subtype 2 were more likely to show stabilization or indeed a slight reduction in tumor size in relation to cabergoline therapy or indeed other dopamine agonists. A nice study actually from Yona Green and colleagues looking at patients who had residual tumor detected either at the start or after follow-up following surgery for non-secretory adenomas. Those who, as soon as there was a suggestion of a remnant post-surgery, were started on treatment were deemed to be in a preventative treatment group versus those who only started dopamine agonist after there was clear evidence of progression of the remnant were in the remedial treatment group and compared to a cohort of individuals who were intent control patients. And again, just looking at clinical outcomes, probably the easiest way to look at this is to look at the Kaplan-Meier tumor progression-free survival curves, showing that in the control group of individuals, the number of individuals who over time were free of tumor progression was obviously at the lowest point. Those who actually had remedial treatment, i.e. when the tumor started to obviously show signs of progressing, were doing slightly better than those in the control arm. But the group who had the most impressive treatment were those who actually went early on to dopamine agonists, suggesting that perhaps dopamine agonists can control the growth of these. And in another study, which actually randomized individuals early on to cabergoline therapy or clinical observation, when we look at tumor volume change at 6, 12, and 24 months, we can see, if anything, there's a tendency for a reduction in tumor volume in those patients actually receiving cabergoline therapy compared to those in the control group. And again, showing quite a separation of the curves on tumor progression-free survival. So moving on, just to remember that also further surgery and optimally timed surgery can be useful in patients with residual tumor or tumor progression. Here's a patient who had a Faust transsphenoidal surgery, and I think most people would agree that there's likely to be a remnant in the left side of the cellar. That remnant then grows, but it takes 6 years before growth happens. The patient then had second transsphenoidal surgery. And at this point, we have an appearance which looks not dissimilar at 3 months after second transsphenoidal to how it did after the first transsphenoidal. But actually, interestingly, at 3 years, if anything, this area is resolving and involuting further. This simply makes the point that further surgery may be indicated, but it doesn't need to be immediate. And in fact, if we can space the timing and there was no threat to the chiasm here, then it gives us the chance to do repeated interventions as and when necessary without overburdening the patient with additional treatment that we can sometimes wait to deliver. Moving on to another case. This is a 54-year-old gentleman with a gradual visual deterioration, which had been worsening over several months on the background of a left amblyopia due to a congenital cataract. There were no stigmata of endocrine dysfunction, but sadly, by the time he came to attention, he had only hand movements in his left eye, and his visual acuity on the right was preserved, albeit with a temporal hemianopia. This was a huge tumor. You can see extensive supracellular extension, but also significant parallel cellular extension on both sides. Remarkably, reasonably good preservation of pituitary function, probably the raised FSH here indicating that this may have been a secretory tumor of a gonadal cell lineage rather than actually this being a marker of primary gonadal failure. The patient went for surgery. There was a good decompression of the central component. The normal gland was not seen, and this was indeed a gonadotroph tumor of SF1. Was not available staining-wise, but we had focal positivity on LH and FSH. Again, nothing exciting on the proliferation markers here. Post-operatively, this is a very good decompression, but we can see that there is still residual tumor around the carotid in the left cavernous sinus. The patient was really keen here to adopt a conservative approach, but actually this was a very extensive tumor, and although it doesn't perhaps show us quite as well on these serial coronal images, we did volumetric imaging on this tumor, which went extensively into the skull base. And at just under 2 years, we actually advised the patient that we thought that further intervention would be necessary. And in this case, we went for radiotherapy because of the extent of the tumor and the fact that we would not be able to surgically resect this. And you can see here that radiotherapy has had an extremely good effect, but 7 years out after that radiotherapy, we can see if anything, there is residual tumor is shrinking in the vicinity of the left cavernous sinus. So again, radiotherapy, but timed radiotherapy here. We bought a little bit of time here, but then we've got a very good result. And then the final case I just want to show is a chap who had progressive visual loss over a short period of time. His only past medical history was gastroesophageal reflux disease, no stigmata of endocrine dysfunction, but again, really quite significant compromise to his vision. Now, this was again a big tumor with significant supracellular extension and already a suggestion of paracellular extension and inferior extension. Again, this is a chap who interestingly had pretty good preservation of a 9 AM cortisol despite a lowish free T4 and a possibly slightly low testosterone. He had a big tumor that was eroding into the sphenoid sinus, no specific comment on the appearance of the normal gland, but this actually, although a non-secretory tumor clinically, actually had diffuse positive stain for ACTH. Interesting, the proliferation marker was not significantly elevated, but this was TPIC positive. Here is the tumor. Post-operative, the vision is improved. At this stage, he only has hypergonadism, but this tumor misbehaves. You can see the first transsphenoidal, and then unfortunately, the tumor grows significantly. The patient has a second transsphenoidal, but in the short window between the transsphenoidal and the follow-up imaging, this tumor has regrown. At that stage, he has radiotherapy. Things seem to stabilize for a while, and indeed, they look as if they're even going to shrink. But unfortunately, this tumor then regrows dramatically in the 1.5 years between scans. He has a third transsphenoidal, and again, it looks as if almost nothing has been achieved at surgery because there's a regrowth very quickly. After careful discussion, a craniotomy is performed because at this stage, unfortunately, this patient had developed a complete cavernous sinus syndrome. And unfortunately, that tumor continued to grow. And really, I just want to finish by saying that it's rare that we need to do this in non-secretory tumors, but here is a case that actually then had to progress to additional therapy with temozolomide, And temozolomide here, after 4 cycles, produced a really dramatic reduction in the size of the tumor and the biomarker ACTH. And this patient retains very good control now. So in summary, I hope I've been able to persuade you that there are very well-trained routes for managing these patients. Reappraisal of the baseline data set is really critically important for decision-making. These patients should be managed through a pituitary tumor center of excellence. Surveillance might be a reasonable option, but that requires all parameters and needs to be thought about very carefully, especially if we're dealing with one of the silent tumors, such as a corticotroph tumor. Alternatively, we may think about repeat surgery, but getting the timing of this right is critically important. We need to try not to be intervening unnecessarily frequently, but obviously to try to mitigate the need for additional treatments. The same really applies when thinking about whether we are or are not going to give radiotherapy. And I think increasingly we need to think about the alternatives for medical therapy and the emerging literature that says that cabergoline may have some preventative roles here in preventing tumor growth or even promote tumor shrinkage. But we also have options such as temozolomide for the rare refractory tumors, especially, for example, the silent corticotroph tumors. I'll say thank you very much for your attention at that point.